my name is Mouhannad Sadek, and this is Dr. Angaran. We're two Toronto electrophysiologists who will be moderating the session. This is a very interesting session. I do a lot of VT ablation, and we've been doing a lot more VT ablation in patients with ischemic heart disease and some other forms of cardiomyopathy. And and it's a procedure where we burn the scar within the heart. We burn within the scar to eliminate the circuits that cause the arrhythmia. And we've been getting to patients earlier in their course with increasing evidence that this is a procedure that prevents arrhythmias. However, in J-wave syndrome, the Brugada syndrome, there hasn't been that much momentum. So it's a very timely topic. Let's show the case. Or I can just read it if it's not. Oh, here we go. So 32-year-old gentleman with Brugada syndrome, spontaneous type 1 ECG with a carrier of pathogenic SCN5A truncating variant, suffered a cardiac arrest at the age of 30, which led to the diagnosis and insertion of a subcutaneous ICD. Also has inferior J waves. The patient contacted Device Clinic because of a jolt the night before, found to have polymorphic VT and VF, treated with a shock, and there was a previous episode noted 3 weeks before. No clear triggers, no medications that would exacerbate the condition, no fever, which can also exacerbate the condition. Echo revealed a normal heart. He did not have an MRI, and the ECG revealed a type 1 pattern. He's otherwise healthy with no drug coverage and is unemployed. So should we ablate this patient or should we put them on medical therapy? I'll let Dr. Angaran introduce our speaker.
Thanks. So on the pro side for Quinidine, we have Dr. Simon Hansom here. So he is an assistant professor and staff electrophysiologist at the University of Ottawa Heart Institute and the director of the Inherited Arrhythmia Service. So he will start with the pro Quinidine side.
Thank you for the introduction. It's a pleasure to be here as always and to be speaking. I've done a debate here a couple of years ago, and it's definitely a more light-hearted part of the day. So we want it to be fun and a little bit engaging. Bear in mind, with any debate, you get slightly polarized views from us. The truth is somewhere in between, and hopefully in the discussion at the end, we can find the middle ground. I feel slightly happier being on the Quinidine side of this argument, but this is a very ablation-heavy panel today. So I'm in a good position. I have no conflicts. With all debates, you have to research the person that you're debating. So Alexios, I actually know him because we were on an ablation course many years ago. He likes VT ablation. Okay, so I'm interested to see what he has to say. When we come to talk about the J-wave syndromes, we're looking at both Brugada and early repolarization. And as we all know very well, sometimes from a personal experience, but from our professional experience, these predispose to life-threatening arrhythmias and sudden death. But we know that there's a shared common similarity in their clinical presentation. We know that men are more predominantly affected. We know that the highest incidence usually occurs in the 3rd decade of life. And we know that often the J-waves are accentuated by bradycardia or following a pause. But we also know that the ECG appearance can be different, and particularly for the early repolarization, it can show different regionality based on the ECG. Here on the left, we see the classical ECG appearance of this coved ST segment elevation in the right precordial leads of Brugada with a T-wave inversion. And then on the right, you see the typical J-wave, which can either be slurred or notched. But also the ST segment that follows it is of relevance because it confers some more information about risk, particularly when it comes to the descending ST segment appearance. We have to get a little bit into physiology to understand why I'm going to talk about Quinidine. And if you like reading physiology papers, actually this is a cracker from 1996. And this was a canine model which looked at the action potential in the epicardium, endocardium, and correlated it to the surface ECG. And the J-wave seemed to line up with this notch in phase 1 of the action potential. And when they gave this drug 4AP, which is an ITO blocker, it reduced some of the effect of this notch. And this notch is important because when we think about the pathology as to why these patients go on to develop arrhythmia, what we see is that if you reduce these depolarizing currents, you actually accentuate this notching. And if you accentuate it to the point that you lose this action potential dome, you get this abnormal repolarization that's scattered in the myocardial tissue that can give rise to phase 2 reentry and arrhythmia. Wouldn't it be great if we had an ITO blocker that you could give that's a tablet? And we do, and it's called Quinidine. And so we have this model from basic physiology that can go through into humans and to our patients. And we'll talk about some of the efficacy of Quinidine, its role in preventing inducible VF at EPS, but also its role in the treatment of patients with J-wave syndromes. Some of the challenges with Quinidine, one of them is it causes side effects, and we'll talk about that. And when you look through the literature, the most dominant side effects that you see are mostly GI disturbance, sometimes photosensitivity, but occasionally blood dyscrasias that can be more serious. The other challenge is access. There's limited sites of manufacture, and we have a lot of regulatory hurdles that can make it challenging for us to obtain this drug that can be life-saving for our patients. And because of this, the cost is high, and therefore the coverage by insurance can also be limited as well. So the first question is, well, is Quinidine actually effective? And this was Belhassan's paper, which probably I've read a lot of papers about this in the last few weeks, and this is by far the most quoted because it's one of the first studies that looked at this. And this was 25 patients with Brugada, 15 was symptomatic, but half of those had things like previous VF or very malignant sounding syncope. They all had an EP study, they were all inducible for VF, and they were commenced on Quinidine, but at a good dose, nearly 1.5 grams a day. They repeated the EP study, and 88% were no longer inducible, and they followed them up for a long period of time, and during that time they saw no arrhythmic events, but they did see that patients had to discontinue because of side effects to the medication. What about if we look at a reduced dose regime? So this was from Silvia Pereira's group, and this was 53 high-risk patients. Most of these had suffered some sort of aborted sudden cardiac death or had malignant syncope, and she matched them to about 400 untreated controls. Much lower dose of Quinidine in this group, around 400 milligrams a day, and only 6% discontinued medication because of side effects. So we see that there is a clear dose response. Higher dose, you're expecting more side effects. But with this, even at a lower dose, we see that the annual rates of life-threatening arrhythmic events drop significantly from 14.7 down to 3.9% in this very high-risk population. Well, what do the guidelines say? Well, the latest, most recent guidelines that we have, actually the European guidelines, suggest that Quinidine should be used or considered in patients who have recurrent ICD shocks. And also in regard to catheter ablation, sorry, Alexios, it should be used where patients are refractory to drug treatment, not as first line. When it comes to ablation, this has just come out. This is from Paponi's work, just came out this year. And these are the headline grabbers for Brugada ablation, where you look at this and you think, why would you not ablate these patients? Because he takes about 250 high-risk patients, he ablates them, every single one of them has normalization of the ECG. And when you follow them up and you look at the number of shocks they get, one person in the ablation arm got a shock, and you look at the group that didn't get ablated, they go on to have significant shock burden. Have I given the game over to you? No, because when you look at the inclusion criteria, you see that actually they excluded patients who had concomitant early repolarization for exactly that reason, and we'll see why in a moment. The other thing I would just point out from this study, I like ablation, you like VT ablation maybe more than I do, but the area that the substrate that they're ablating is enormous. They're giving adrenaline to provoke and to bring out the substrate, and they're ablating a median of 25 square centimeters. And the one patient that had recurrence had a 56 square centimeter substrate that they reablated. This is a massive amount of ablation. So if we turn a little bit towards our patient, this is a fantastic work from this ongoing multi-center international registry from Nadamani. And they took 159 patients, and about a third of them had both a type 1 Brugada and an early repolarization pattern. So this fits more with the patient that we've just discussed at the case. He's not a slam dunk type 1 Brugada, he has other bits added in. And we see a few things. Number one, we see that yes, they all have substrate where we expect for Brugada in the RVOT, RV epicardium, but now about 30% have substrate elsewhere, inferior RV, epicardium, and some of them on the left as well. And this is more realistic, I think. 13% was still inducible following the procedure. 17% still had a type 1 Brugada pattern. And following a first procedure, the success rate was about 81%. While there was no inpatient mortality, there were serious peri-procedural complications in 4 patients. One had severe pericarditis in addition to those. Another one developed sustained monomorphic VT on the same day that required an expedited ablation to resolve. And interestingly, following ablation, 3 patients stayed on quinidine, and 2 of those were people who had concomitant early repolarization. Nadamani himself, at the end of that paper, made a comment and said that Brugada and the early repolarization ECG pattern may continue to have risk of VF recurrence, even though the type 1 Brugada pattern normalizes. And that's something important that we have to bear in mind when we see patients like this. So in summary, quinidine is the only oral targeted ITO therapy that we have, and I've shown you that it is effective in suppressing ventricular arrhythmia, and we can minimize side effects with reduced doses. I would also make the point that these outcomes, 81% first procedure success, is from a highly specialized center. We don't do a huge volume of Brugada ablation, and if you're going to quote a risk or a success to a patient, quoting something that comes from a very high volume center, we'd have to be careful with that because we may not be able to achieve that in the early stages. So coming back to our patient, he's naive to medical therapy. He's likely to have extensive substrate. We just spoke about what procedure success you may quote for him. We do not know the long-term implications for this man's ventricle. He's young. He's going to have extensive ablation if that's what we do at an early stage. And we don't know the risk of iatrogenic VT following what we do. We also know that he may go on to have recurrence of the pattern, recurrence of arrhythmia, and end up back on quinidine anyway. The other challenge, which we may talk about during the questions, is how you do a second epicardial ablation, because often you have adhesions and it can be a very difficult procedure. So final words, Nadamani himself, just to remind you his caution about patients with Brugada, type 1 Brugada, and early repolarization. But the final word, ablation is currently indicated for those who experience recurrent ICD shocks, despite medical therapy, or for those who are intolerant to medical therapy. Alexios, who do you think said that? Who do you think said that? Andrew. So you can disagree with me, but you have to disagree with Andrew at HiRO. There we go. Thanks so much.
Well, that was nicely done and going to be a hard act to follow. On the pro-ablation side is Dr. Alexios Hadjis. This CV here is too long, so I'm just going to shorten it up in the sake of time. He's a clinical assistant professor at the University de Montréal and director of cardiac EP in Montreal. He did his EP fellowship at UCSF and did further subspecialization in Milan in complex ventricular arrhythmias.
We're rooting for you.
Thank you very much for that super kind introduction. Also, thank you to Jason for the invitation. I'm really quite honored to be amongst you all today. An electrophysiologist that I admire very much, who currently works at UCSF and probably mentored quite a few of the EPs in this room today, always says that at the end of the day, it boils down to EGM, meaning the signal, the electrogram that we see in the heart. During cases when I was a fellow, he also would say that this is not the helicopter school of mapping. Move the catheter gently. It's an EP joke. Forget it. Don't worry. Things have changed quite a bit in terms of ventricular arrhythmia mapping. So we're now in the era of multipolar, high-density mapping where we're able to accumulate, analyze, and process a lot of information very rapidly. So each one of these points is a single EGM that we are able to interpret. So if you would allow me, I'm going to present very briefly another case that's quite similar to ours of a 52-year-old gentleman with Brugada syndrome who had symptomatic recurrent ventricular arrhythmias, and this was despite taking quinidine, though he did note lightheadedness, nausea, and diarrhea. we brought this patient to the lab, and immediately upon mapping, so we went endocardial and epicardial up front, we noticed that quite fractionated EGMs in the epicardium right away that we brought out with atrial pacing. Spontaneously, we would see intermittent epicardial late potentials. Then on procainamide infusion, after a few PVCs, he actually develops brugada pattern, which you can see there in V1. And again, we're bringing out these epicardial potentials. So here are two maps. These are basically our reconstruction of the heart. So purple being healthy tissue, and those green dots are some very, very interesting signals and essentially a rhythmic substrate. So we see it right in front of our eyes that this is clearly the substrate to sustain arrhythmia. Obviously, when we're in the epicardium, we have to be judicious and be careful. So when you're ablating in the epicardial space, you want to be sure not to touch the coronary arteries. So we always shoot a coronary angiogram prior to ablating. So you make sure that you're a safe distance away, or the one on the right, we're a little bit close there for comfort. However, we target the area and we ablate. So all of those on the image on the right, you have those red dots, which is the area that we ablated. Following ablation, we actually had loss of brugada pattern. So moving your eyes from left to right on the screen, you see resolution of the brugada pattern. How was the follow-up for the patient? Number one, there was no NSVT, no VT-VF therapy. This is the best I've felt in 9 years. He believes his memory is improved. Now after stopping quinidine, which caused mental fogginess. This is just perfect, okay? So the reason I bring this up is that the J-wave syndrome, so brugada, early repolarization, even idiopathic VF, we're beginning to think that there may be a common subepicardial cardiomyopathy. So this is non-transmural, subtle, microstructural abnormalities that are bringing out these arrhythmias through, obviously, impaired sodium conduction, genetic factors, environmental factors, but the end result is a subepicardial arrhythmogenic substrate. Now, this may vary in terms of when it becomes overt, which we may pick up on an MRI, but often the epicardial abnormalities we can pick up earlier in the process, and if we can detect them earlier, we can target them as well. So our own institution's experience, we reported on a early repolarization patient who was having recurrent VF and recurrent shocks, whom we did bring to the lab. And in fact, we did note abnormal epicardial substrate, very similar to brugada, even though he did not have brugada syndrome. And in fact, we targeted that for ablation. This is another patient who had idiopathic VF. Again, you see those squiggly lines? This is abnormal. This is a fractionated EGM, and very strange to find in a structurally normal heart. I'm glad Simon brought this up. This is a very nice study, the Nadamani paper, and it's exactly as he described. So 159 patients with brugada syndrome, although 27% had concurrent early repolarization pattern. They all went on epicardial mapping. What did they find? In 100% of the patients, they had epicardial substrate overlying the RV. Some had in the inferior RV, and a small group had in the posterolateral LV. So after a single ablation procedure, 81% patients remained VF-free, 96% after a repeated procedure. 96% of patients were VF-free. And the only variable associated with VF-free outcome was the normalization of the type 1 brugada pattern. Okay, there were complications, including 4 patients who had hemopericardium. Now, the question of our patient and the debate also had concurrent early repolarization syndrome. There's also this paper that showed 52 patients with early repolarization syndrome who were also all taken for endoepicardial mapping. They divided these patients into 2 groups. So group 1 had identifiable arrhythmogenic substrate in the epicardium, and group 2 had no abnormal signals despite extensive endoepicardial mapping. Group 1 was then further subdivided. So there was 33 patients with early repolarization syndrome and Brugada pattern. So this is an example. This is another map where they show areas of the ventricle with the corresponding EGM, and you see the ECG on top of it. So in the inferior RV, you see that early repolarization pattern, you see that fragmented EGM. So what did they show? That after the first ablation, 67% were free of VF, and after the last ablation was 91%. However, all group 1 patients, when they looked back, who were treated with quinidine, failed to respond to the drug, whereas 50% of the group 2 patients had responded to quinidine. So it's possible that we can, after endoepicardial mapping, identify those patients who will respond to quinidine versus those who will fail. Now, I don't want to poo-poo quinidine. I prescribe it myself, it's fine. But as Simon mentioned, there is a challenge. And in fact, the challenge to access, I think like 90% of the authors of this paper are in this room, okay? So it's not easy. There's breakthrough VF potential and any interruption of the therapy. This is not great. It's not ideal. Last thing I would mention, which it's not benign. So epicardial mapping, it's how can I describe it? It's like doing a pericardiocentesis, but there's no liquid, there's no fluid. So it's sort of a dry tap. And so it's not a benign procedure. So I would like to echo the sentiment that it needs to be, as long as it's in the hands of an experienced center with like a good amount of cases, I think it can be done safely. And even most recently at HRS, newer techniques are being developed, either CO2 insufflation, where it's becoming a safer and safer procedure in order to access the epicardial space, to the point that we're even doing that on patients with compelling reasons for anticoagulation, on uninterrupted anticoagulation, which was also presented at HRS. So, end message that I want to get through. Number one, ablation in J-wave syndromes is safe. It's effective in preventing VF recurrence. And at the end of the day, it boils down to EGM. Thank you very much.
Maybe I'll start with a question, a more realistic scenario. Let's say our 32-year-old patient has been placed on quinidine, stable. He comes to your office. I have a foggy memory, a bit of diarrhea. I want to travel. I don't want to take this medication. I want to be cured. What would you tell him? He hasn't had any shocks, any therapies. 30 seconds each. That's okay.
Yeah, I mean, this is the question of cure. His ECG is grossly abnormal, and I'd be very cautious as to what I advised him in that sense. Whether you'd ever achieve a cure, I think Nadamane's paper proved very well that those that have a more complex pattern of disease, particularly with very diffuse early repolarization, often don't do as well from ablation. I think I agree with Alexios. I think the outcomes can be good from ablation if you want to do it twice. But 60-odd% for a full, that's several hours of ablation and epicardial, and then redoing epicardial access again. It's tough, and we don't know the long-term outcome. It's also interesting when you look at the data that those studies that lean more towards ablation have a very high failure rate of quinidine. And you look at more the medically managed ones, they seem to tolerate it much better. So yeah, I'd have a discussion with a patient. Personally, I would probably, I'd give him the best advice that I could based on the current data, but I'd be wary of him having ablation if he's had no issues and he's reasonably tolerating the quinidine.
I have to admit, it's very difficult. It's a difficult scenario. It really, obviously, would take a longer discussion with the patient just to see how debilitating his symptoms, side effects are. It's very difficult to convince myself, at least, to bring a patient on the table, as you said, who's had no therapies and seems to be doing quite well on quinidine. So I think that would take a little bit longer discussion. But I mean, really, it's the patient's quality of life as well, in the sense that if he's really not tolerating the quinidine, I'm not going to force him to take it. He'll probably stop taking it anyways, as we discussed before about compliance. So I think I would try to take it to the limit before putting them on the table.
Go ahead. Thanks, Paul. I think there's a problem here. We've used, as if they are the same, early repolarization, J-wave, and Brugada syndrome. I don't think they are the same, number one, and I think I'm pretty convinced, maybe wrong on this one as well, that Brugada syndrome is largely a depolarization issue. I'm not so sure that's true for the J-wave syndrome. We call early repolarization. Some of that may be depolarization. And the J-wave syndrome, some of that may be a repolarization issue. And I think to say that this is all one thing and talk about them interchangeably, I think is probably wrong. And I think the repolarization syndromes are probably best treated with medications if we can target the right medications to the right disease. And the depolarization syndromes, it seems to me, might be better targeted with ablation, where we actually can change depolarization. I just wonder your thoughts on that.
Yeah, I completely agree with you. I'd intentionally tried to avoid the discussion as to whether this was a depolarization or repolarization issue. I've read most of the literature and I agree there's good arguments from both sides, but I agree with what you're saying. There are patterns that would suggest they fall into a similar group on a spectrum, but whether our approach can be singular in that sense, I agree. I don't think we have all the information that we need at this stage.
I agree, and Dr. Green, what I would say was a lot of the cases or a lot of the situations that there's a lot of overlap. And I thought that the Nadamani paper, I thought that was very interesting. What they showed is that after mapping, there was a clear differentiation between those that had abnormal substrate or abnormal EGMs and those that did not. And those that did not, in fact, did benefit greatly much more from medications. So I'm not against what you said, but I wonder maybe, again, to come back to the debate, maybe should we switch the order? I'm not saying we should ablate everybody. I don't want this. Half of this was for show, huh? But I wonder if we should be doing the mapping first, and maybe that will help us differentiate a little bit more between the two.
I think it's both, like the depolarization and repolarization. I think they're operative in both, in Brugada and ERS, and Nadamani and Alexios are both right.
I just have a quick question about the natural history of the disease. This person's had 2 events, but clearly there's going to be some patients with 5, 6, 8 events per year, and they clearly need something. But from what we've seen from the natural history, it's pretty unpredictable in a young patient. If somebody has one single event, potentially even spontaneously terminable, depends how you program the defibrillator. If you program a long detect interval, that's why people have syncope and don't die. So if a person's had a single event of potentially self-terminating arrhythmia or requiring one shock, and their next event is destined to be in 7 years, I'm not sure we need to do anything if they have a defibrillator. Remember, we're trying to treat quality of life because it's a defibrillator that's going to prevent them from, unless we're prepared to not to put in a defibrillator and to use these as monotherapies, I think we have to reserve the opportunity to do nothing. Leave the defibrillator in, reassure the patient, and see what happens.
Just a question for Alexios. Your EGMs are impressive. My question is, if it's all about the EGM, explain how, I guess essentially maybe a channelopathy or a dysfunctioning transient outward current leads to EGMs that look like that. Like, how do we go from an electrical problem to a substrate problem?
I'd actually like to pass that to the panel as well. I have thoughts, but I wouldn't mind hearing what everybody thinks, because I do think that this is a contentious point a little bit in terms of the pathophysiology of the disease.
So there is a published paper. Is it Nakagawa who looked
I think we have an answer here at the table, actually.
There may or may not be an answer, but there was a presentation about 7 or 8 years ago at one of the early HRS meetings in a mouse model of sodium channel abnormalities. If this starts early in fetal life, it can lead to secondary structural remodeling because of an imbalance of contraction forces. The ITO current is really what's responsible for the ventricular peristalsis. It's the distribution of ITO around the heart that is responsible for how the heart sequentially contracts from apex to base. So if you disturb depolarization, you can disturb contractility, which in turn leads to kind of a secondary structural abnormality. So it's a consequence of the ion channel problem, but it's a structural problem as a secondary event.
Excellent. I think we're going to skip the break, so we'll probably end there, if that's okay. Do you have one more?
One quick follow-up. Do you think that disruption of any parasympathetic ganglion could be involved in some of the success after you do extensive ablation?
I'm not sure. I'm not sure. I think the locations vary. I think sometimes some of the locations, they might not correspond. And in fact, I can't say I've noticed that, at least in our center's experience, or nothing that I picked up in the literature as well, looking over that. But it's a very good thought.
Great.
Can I just say, the whole field of cardiomyopathy is starting to, and maybe this isn't the right forum, but you wonder if in these patients, there may be a crossover of therapeutic effect, but that's a whole different